Okay, well, hopefully we're live. It says meeting is now streaming live, so that's a good sign. Welcome to Doc Talk Live. I'm with Brian Sue of California Orthopedics and Spine. Brian, welcome. Thanks for coming on today. I can't hear you. There you go. Okay, now I hear you. So Dr. Sue, I appreciate you taking time out of your busy day. I sort of looked you up online, and you have a very, very impressive pedigree. Duke Engineering, Columbia Medical School, then you went to the Rothman Institute. So wow. But really, one of the things that you do, which is kind of cool, is you've got a YouTube channel called The Spine Guy, which is about providing patient education. Can you tell us a little bit about that to start off with?
Sure. I've always been into teaching, whether it be residents, fellows, other surgeons, and I still try to stay involved in academic medicine, even though I'm in private practice. And I realize that so much of that education is patient education. And a lot of the visit is spent, talking about a specific pathology, whether or not it's cervical stenosis, lumbar stenosis, reading an MRI. And a few years ago, and I'm sure any doctor that takes care of a lot of patients, I have like my bread and butter 10 things I take care of. And I may say the same thing to patients 20 times a day. And it's the same exact thing. And often patients forget because there's a lot of information. And if I'm spending time trying to educate the patient, it's just a ton of information for them to retain. And so my wife actually had this idea for me a couple of years ago. She's like, why don't you just start a YouTube channel, and all the stuff that you normally say to a patient, just record it, edit it. And my brother-in-law, edits videos. So I record this stuff at my house, and we decided to do it based on pathology. So cervical radiculopathy is a pinched nerve of the neck. So I did an episode on the symptoms, what causes it, the non-surgical treatments. So now when a patient comes in, I give them a handout and I say, hey, listen, if you don't remember the stuff that I told you today, it's on YouTube. It's basically the same thing I told you, so you can watch it again.
That's
interestingly
awesome. So how do people find this, Brian?
It's kind of just grown organically. It's been about a year or so. I think I have over 1,000 subscribers, and I never really intended this to be anything other than just educating patients. And so I think
so just go to YouTube, in the search engine, type in the Spine Guy.
Yeah.
Or Brian Sue, S-U.
That's right. Yeah. And they can, check out all the other videos that are for different pathologies. But I try to put out one every other week, but it's challenging with my schedule.
So one of the things we briefly talked about, and I want you to talk more about this, I sort of cut you off, is we were talking about neck problems. And, I see this in my practice a lot, where people really have incredibly bad looking cervical spines or bad looking necks, such that, and I'm going to quote myself, and please feel free to pick me to shards, okay? But I will say, I know you're doing well, but you are the person I would hate to see get into a car accident. Please make sure you wear your seatbelt. Because there is no room for the cord. It just amazes me that they're walking, they have no weakness, they have no symptoms, and I'm just concerned that they're sort of a problem waiting to happen. And since you're decompressing these cords, in fact, you might even see the cord behind me. My fiance painted that for me.
Like that?
C56. So that's what we're talking about, is the spinal cord there. And how do I advise patients about their risk of ending up like Christopher Reeves or Superman?
It's a complicated discussion. I'll try to kind of boil it down in a few minutes. I think firstly, it's important for everyone listening to understand that everybody gets nerve, spinal cord, and disc degeneration as they age. If you were to MRI an average person over the age of even 40, up to a third, and if they're over 50, up to 75% may have disc degeneration, stenosis, which is merely pinching of the cord or nerve. It doesn't mean it's a problem. I'm always telling patients we're treating you, not the MRI. To me,
and it's frustrating because the MRI it can
Yeah, it
look a
can look
lot
bad.
worse than the
Yeah, it can
problem.
look bad.
I call that gray hair of the neck. You've got,
Right.
you know,
So it's a part of
aging.
routine aging, right? So we study this pretty specifically. I'm in the Cervical Spine Research Society, and all we do is we kind of study the cervical spine and look at what happens as people age and what surgical interventions are appropriate. And it's actually fairly simple, and the recommendations are fairly simple. If you have severe spinal cord compression of the neck and you're totally asymptomatic, and the symptoms of spinal cord compression is basically something called myelopathy. And myelopathy is problems with fine motor skills, numbness in the hands, weakness, bladder dysfunction, lower extremity dysfunction, lower extremity balance problems. If you have those symptoms, and we grade them from mild to severe, mild, somebody might say, I have a little bit of numbness, dexterity issues. Some people might say, I can't even use my hands. In North America, people don't usually get it to be that severe. Usually we're seeing people that have a little bit of numbness, a little bit of fine dexterity issues. Really, the recommendation is we can try conservative care, sometimes epidural, sometimes collar wear, sometimes PT. But really, we found that those patients really should be intervened on surgically if they also have spinal cord compression. Now, the patients that are asymptomatic, and notice that myelopathy doesn't include pain. Myelopathy is a neurological finding. Patients may or may not get pain from cord compression. Really, we're worried about the fine dexterity, the numbness stuff. A lot of patients get neck pain even without cord compression. So if you have cord compression and you come in with neck pain, I get an MRI and say, wow, that cord is pretty compressed. If you are not myelopathic, we do not recommend surgery.
Let's just stop there for a second, because there's an interesting comment that just came in through the feed, Brian, and June says, I had a migraine for a week from my neck. So first of all, a lot of times migraines aren't migraines. Headaches are actually referred from the neck.
Yeah, cervicogenic headaches.
A cervicogenic headache. And so how would you address that from a ortho spine standpoint?
Sure, I think, so in terms of, let me just finish the one point about the cord compression. So what you tell patients, which is, and that's what I tell patients, if they have a tight spinal cord and they're not myelopathic, I say, you definitely have an increased chance of becoming paralyzed if you get into a car accident or fall relative to the average person. But it doesn't mean we should preventatively operate on your neck, because the risk of paralysis with neck surgery is actually higher than the risk of paralysis if you get into a car accident. So you're correct in telling patients to be careful. I tell them to sometimes wear a collar in the car if they're really stenotic, or I tell them, don't go bungee jumping, triple black diamond skiing, etc. But I certainly don't say we have to do a preventative surgery on your neck.
Okay.
Just because you fall doesn't mean you're going to become paralyzed.
So you have to have some.
You have to have symptoms in order to get surgery.
And I see patients where the cord has myelomalacia. Maybe you could tell our viewers what myelomalacia is, and they have no symptoms.
That's right. So that's kind of the inner aspect of the cord starting to die off a little bit, actually. It turns white. So you kind of see these snake eyes appearances, like where it's red behind you, the red part turns white. And so
right in here.
Yeah, it's basically some of the matter starting to degrade. If you're asymptomatic from it, there actually is some debate now about whether or not that should be decompressed. That's kind of a gray area, if you will. But in my practice, if they have myelomalacia, they're totally asymptomatic, I still watch it. If they have cord edema, which is bruising of the cord, that's kind of different than myelomalacia. Bruising of the cord also shows up as bright, but it's a swelling of the cord. In terms of the cervicogenic headaches, that can come from any cervical pathology. A pinched nerve in the neck, the facet joint was the joint in the back of the neck, spinal cord compression, nerve compression. How I differentiate it is with injections. Meaning if you have neck pain and you have a headache and you treat the facet pain and the headache goes away, then we know it's cervicogenic. If you have arm pain or a pinched nerve and we do a cervical epidural or a cervical selective nerve root where we numb the nerve or put steroid over it and the neck pain and headache goes away, then we know it's cervicogenic. There are definitely patients I've operated on that have cervicogenic headaches we treat the cervical pathology and their headaches go away.
Absolutely.
You know, that's a
Absolutely.
very common thing, and that's known in the literature actually. There's like an
Absolutely.
80% chance of reduction in cervicogenic pain if you treat the cervical pathology. You just have to know it's cervicogenic. So I use those injections to kind of delineate that, and that's a
Get an
terrific
idea
question.
of
Yeah.
how they will respond. Um, I know you have an interest in disc replacement. Maybe you could speak a little bit about when you would actually replace the
Sure.
disc. They don't do that a lot here down south, and I have a feeling it's more because of insurance is not readily reimbursed here.
Almost all insurances pay for it now.
Okay.
That has changed significantly last year to two, because the data now, which is we have up to 15-year data for two-level disc replacement, and for two-level surgery for the appropriate patient, if it were my neck, that's what I would get. The outcomes are clearly better based on patient-reported outcomes. I'll share this is actually for my YouTube channel. Oh, you have to enable screen sharing.
Let you screen share
Yeah.
multiple. Okay, so now you should be able to
So this
use your
is,
screen.
you're probably looking at this YouTube screen, right?
Yes.
So this is the neck, this is the back of the neck, there's the front. So these are the bones here, and these are the discs, which are the cushion between the bones. Now, sometimes what can happen is, a disc could herniate out and hit the spinal cord or hit the nerve. And this is what we used to do in everyone, which is essentially take the disc out, put bone or a cage in, and put a plate with screws to make it solid and eliminate the problem. This is an outstanding operation and one of the best surgeries we have. The problem is when you start doing more and more levels, it's not so much about taking the motion away, it's about the adjacent levels.
Yep.
And what can happen is the adjacent level can break down over time because this level is now fixed. So these levels above and below pick up the slack. A disc replacement, this happens to be the Mobi-C disc replacement. There are many on the market. Mobi-C is kind of the one that has the most two-level data, two levels meaning at both levels. But it's basically like a total knee replacement. It's a plastic implant in the middle, and it's a metal shell that gets implanted. And I'll forward through this and kind of show you what it looks like. So this is what the disc replacement looks like. There's a metal piece that goes above and below, and there's a plastic piece in the middle. And what happens is once we take the disc out, take the pressure off the nerve of the cord, we implant this plastic piece, and you'll see that there's plenty of motion that happens forward, backwards, up, down, because it's not a fusion. So that's what a disc replacement is. And preliminarily, particularly at two levels, the outcomes have shown to be better, and the adjacent level disease is a little bit less as well. So, for me, for the appropriate patients, a disc replacement is a good thing. I think, like any new technology, the key is not to overuse the technology, because that's when you run into problems. And I think, there's been more and more disc replacement being done, and in fairness, industry has pushed this. We got to be really careful. Disc replacements are not great for people that are older because of osteoporosis. Sometimes that metal plate can collapse in. Disc replacements are not good for people that have also facet arthritis, because if you've taken the disc out and you maintain motion, but some of the pain's coming from the posterior facet, you shouldn't do it in patients with that. And also, if there's a lot of degeneration, a disc replacement is not used to restore motion. It's used to maintain motion. So disc replacement needs to be done in somebody that already has pretty good range of motion, not in somebody that has a lot of arthritis and degeneration.
What are your thoughts about, I tend to say to patients that everything works better in the neck than in the low back. So I always say, like, surgery works better in the neck than in the low back. Blocks work better in the neck than in the low back. What are your thoughts on disc replacement in the lower back, in the lumbar spine?
Yeah, you're definitely right about that. It kind of depends, right? Like if somebody's getting a discectomy for sciatica, that's a better operation than getting neck surgery for neck pain, right? So I think, in general, I would say surgery for nerve compression is better than surgery for axial pain, meaning neck pain or back pain. But disc replacement, there's no question, and the cervical spine has taken off more. because the outcomes have been a little bit better. There's one huge difference though. The FDA indications for a disc replacement in the lumbar spine is for degenerative disc disease, meaning a disc is bad, it's collapsed, it's causing pain. So you either do a fusion or you do a disc replacement. The problem is even the gold standard, which is the fusion, doesn't have very good outcomes. And I have a whole video series on degenerative disc disease, when you should and shouldn't get surgery. In general, surgery for degenerative disc disease, even in the best of times, i.e. a fusion, has not great outcomes. In the cervical spine, the FDA trials, it wasn't for degenerative disc disease in the neck or neck pain, it was for arm pain from a pinched nerve. And so the gold standard for that, cervical fusion, has awesome outcomes. And so you're comparing something that has awesome outcomes for an indication that's really good in the cervical spine to the lumbar spine, which has very poor outcomes, even in the best of situations.
Right.
And I think probably for that reason, lumbar disc replacements haven't really taken off as much as cervical.
That would lead me to bring up stem cells with you,
Sure.
which, I see that as potentially a strong future if we could dial in the science and really, really do something that is meaningful in terms of stimulating the disc to undegenerate or repair itself. I don't know where you stand on that, so I'll leave the floor to you on that.
So when we're talking about stem cells, we have to be careful because the industry uses stem cells as a word to cover many things. I've heard patients say PRP, which is plasma replacement protein, is stem cells. I've heard patients say embryologic stem cells are stem cells, meaning you take it from the embryo. There's some companies that say there are stem cells. Understand one cell differentiates into fat, skin, cartilage, bone. And you have to signal that cell to do something. So this gets extremely technical, but let's assume that you could put a cell that's going to grow into something that's going to help kind of replace the inside of a disc for degenerative disc disease. The signaling has to be right, meaning the local signaling has to allow it to grow into the collagen that is the disc. I think it's incredibly exciting. There's actually a recent paper just published on allogenic stem cells for degenerative disc disease. Small series was published in Spine Journal. I think it's promising. I think we need really good level 1 evidence in order to really, really figure out if it works. And it has to be controlled with injecting saline, because I think there's a huge placebo effect to patients who are cash paying for stem cells or PRP.
I agree.
Some of the data is super encouraging, but I have guarded optimism. But I think there is optimism.
We've been involved in several stem cell trials, and the saline group, we call it the holy water, because the holy water oftentimes beats the cells.
It's so interesting. There was that New England Journal of Medicine paper published a few years ago on epidural steroid injections and whether or not you even needed the steroids. So, they did 2 arms. They just, one arm, they just used local anesthetic, and the other arm, they used local anesthetic plus steroid. And the local anesthetic group basically did as well as the steroid group.
Yeah, that is a complicated discussion, but I love it. Local anesthetics. It's the same reason when you operate, you anesthetize the skin before you make an incision, even though they're asleep. There is something about local anesthetics and pain that's powerful. Before we finish up, Brian, I want to just address with you maybe some myths about spine pain. Like, in the old days, we used to tell people they just need to rest and their back will get better. So that's like one of those obvious myths, like bed rest is good for back pain. It really isn't. There's no evidence that one should rest when they have a back attack. Not that they feel like being active, but rest really doesn't help your spine. Smoking's people don't really believe that smoking can affect their spine. And maybe you could comment on smoking.
Smoking affects my patients in two ways. One is when you operate on someone, there's no question that smoking inhibits fusion. And it's not even just the smoking, it's the nicotine. Nicotine itself, that chemical, if you were to take a cervical fusion patient and they smoke versus not, they have a 50% increased chance of not healing. There's no question. Even before they get to the surgical point, there's no question that smoking is linked to degenerative disc disease. And that data is very well known. And in fact, if I have a patient that has degenerative disc disease, I will refuse to operate on them, not because they won't fuse if I operate on them, which they might not because they're smoking, but because sometimes stopping smoking gets rid of their back pain.
Interesting. Interesting.
I've seen patients stop smoking, lose weight, do core strengthening, and their back pain goes away. And smoking is a huge part of that. So that is definitely is not a myth. That's a scientific
right.
fact.
I don't mean to say it's a myth.
Yeah.
The myth would be when the patients say, "Hey, smoking has nothing to do."
Oh
with
yeah. No,
with
it's
my
very
pain."
well. That's very well known.
No, I didn't mean to imply it the other way, Brian. I meant to say that patients have a hard time accepting that smoking has anything to do with back pain.
Right. Yeah. And so does sitting, and so does obesity.
Talk to us about obesity. What are your thoughts on obesity and back pain?
It's a mechanics problem. Pressure is force over cross-sectional area. The cross-sectional area of a disc is like that.
Right.
So as you sit, you increase pressure, and as you put on belly weight, you increase pressure. So the force increases, but the cross-sectional area stays the same because you can't increase the cross-sectional area of your spine.
If somebody, though, puts on, let's say, weight over a 2-year period, wouldn't that be different than somebody who's been heavy their whole life, who's sort of, because their bones will be stronger, their discs will be stronger. Not that I'm advocating people to be heavy throughout their life, but almost the way they're developing a stronger spine, if you will, because they have more. It's like weightlifting.
Yeah, I think so morbid obesity is different than somebody that's obese, right, or bigger. If you have a bigger frame throughout your entire life, that's definitely different than somebody that's like put on 50 pounds over 2 years.
Exactly.
I think that's a valid point. And when I take a patient history and I see somebody is obese, I actually say, tell me about your weight. It's gone up, it's gone down. And some people say, I recently gained 50 pounds. Some people say, I've been like this for 20 years and I've always had back pain. Those are really different patients.
So Brian, last thing, how did you end up on the West Coast? I mean, it seemed like you started on the East Coast and now you're on the West Coast. So how did you get out to the West Coast?
My sister's out here. She's in Sunnyvale in the Bay Area. And a lot of my family's out here. And my wife's family's from Vancouver. My wife's Canadian. So we were looking at kind of the West Coast and ended up in Marin. Marin's beautiful. Unfortunately, it's insanely expensive, but it's very beautiful. So when I came out here, it was just so nice.
So you grew up where?
I grew up in upstate New York.
Okay. And so
I've been a New Yorker my whole life.
Are you a skier?
A little bit.
A little bit. What's your primary sport? I'm just curious.
I played a lot of volleyball, actually. I look short here, but I'm 6'5".
Really?
Yeah. And,
wow.
In my prime days, I was like 6'5", 225. And before I hurt my back, I actually have an L4 spondylolysis. But I played volleyball throughout high school very competitively. I played a little bit at Duke.
Nice.
And then I hurt my back. So I still try to stay active. But yeah, you can't tell I'm tall because of the Zoom screen.
So what do you do for your spine?
I do a lot of PT, core strength. I actually do supine rowing. So I have a water rower at home. I try to have a standing desk. The problem is spine surgery is like really bad mechanics because I'm wearing loops and a headlight and my neck's always like that. So, it's not ideal, but I try to stay relatively fit.
Do you ever get blocks or anything like that?
Never had an epidural.
Good for you.
I don't have any leg pain, just back pain. Thank God, no leg pain so far.
Well, you could get, you could get medicine put around the pars, I suppose.
Yeah, I mean, I would say like back pain and neck pain are usually tolerable. Arm pain and leg pain, that's not tolerable. Nerve pain, you know that. You see a lot of
Of
patients.
course.
Nerve pain is not tolerable.
All right. Well, Brian, how do people find you again? The spine guy on YouTube would be a great way.
Yep.
I think somebody posted a link to your under the comments. Somebody posted a link to get to you, so that'll be good.
Cool.
And I appreciate it. I want to thank you so much for doing this.
Hey, thanks so much for having a way that the public can understand.
Yeah, and a shout out to your
actually
group, California Orthopedics and Spine. It sounds like you guys really have some cutting edge doctors there that are, looking for minimally invasive ways of really getting huge results.
Yeah, we got a great group here.
Thanks, Brian.
All right, Brad. Thanks so much.
All right.
All right, take
Bye.
care. Bye.
All right, let me see how I end this. There it is. End.